Everyone, I'm Dr. Rehman. I'm a first year emergency medicine registrar and in the VIT circuit. And today I'll be giving a talk about dysrhythmias. So the aim of this talk is just to give a practical approach to how to identify and implement the emergency management of the most common dysrhythmias that we do see in the emergency department. The outline of my talk, we're going to first go through what normal sinus rhythm is, because it's just important to know what's normal before we figure out what's abnormal. It also helps in terms of the calculations and stuff with the different intervals and the different waves and stuff. And then we'll talk about atrial fibrillation and flutter. Atrial fibrillation is quite a big topic, but I'll just go through the basics. And if you do want more information, you can read up on it further. Bradycardias and AV blocks are quite interesting, so we'll go through those as well. And then the SVTs. So SVTs do have a bit of a complicated pathophysiology behind them, but the management is it's quite fun. So it'd be nice to go through that. And then ventricular tachycardia, VFib, those are your the PEAs and Asystole. So those are your pulseless cardiac arrest rhythms in ACLS. So we'll touch on those at the end. So before we start, I just want to play this here. So it's just a video showing how the impulses travel. So from the right side of the heart and the SA node, and then moving towards the AV node. The AV node sort of gatekeeps the rate from the SA node, and then from the AV node goes to the bundle of His, and then through the bundle branches, and then into the Purkinje fibers and into the myocytes, which depolarize and cause systole in the myocytes of the ventricles, right? The image on the right side of your screen is quite important to know when you're looking at the vectors or the electricity of how the electrical impulses are traveling and what you're actually seeing on your ECG leads, your 12 lead. So it assists in trying to figure out what sort of arrhythmia you're looking at. V1 and V2, as you can see in these areas here, look at the right side of the heart. And you usually correlate these with your AVR on your limb leads. And then V5 and V6 would look at the left side of the heart, and you correlate those with your limb leads, which are 1, 2, and AVL. So in terms of sinus rhythm, there's just some important things I want to point out here. Your normal P wave is 3 small squares and 2.5 squares tall. The PR interval, which becomes important in heart blocks, should be between 3 to 5 small squares. So a prolonged PR would be more than 5 small squares. A normal QRS width. So when you're looking at your dysrhythmias, when you're saying whether it's a narrow complex or wide complex, your narrow complex would be 70 to 100 milliseconds, so that's less than 2.5 blocks, and then more than that would be wide complex. The QT interval then is also important with dysrhythmias. So a normal QT interval for males is 440 milliseconds, for females is 460 milliseconds. In general, if it's more than 500 milliseconds, that's the prolonged QT that's associated with torsade dysrhythmia. If you do have a bradycardia, you'd want to, if you had a bradycardia, you'd want to correct the QT interval, or if you have a tachycardia. So with a tachycardia, you'd have a longer QT, and with a bradycardia, you have a shorter QT. But to correct it, you divide the QT interval by the square root of the RR interval. So in this ECG, it's just to show you a normal ECG. So you can tell it's a sinus rhythm because there's upright P waves in leads 1, 2, AVF. These are the leads that look at the sort of the left bottom side of the heart. So the in that video you saw before from the SA node, as the impulse was traveling downwards towards the apex of the heart, it does travel in that direction. So those are the leads where you expect a positive P wave and then negative P in AVR. If you have those, that gives you an indication that it's a sinus rhythm. And then the normal excess with equiphasic QRS in AVL, and positive in lead 2. So that's normal axis on this ECG. So just some basic terminology. Our dysrhythmias generally divide them into two, so they can either be fast or slow. So fast would be a rate of more than 100 beats, and which are tachycardias, and then slow with the rate less than 60, which are bradycardias or Brady dysrhythmias. If you see an arrhythmia with narrow complex, so that's your supraventricular, which means the dysrhythmia is arising from above the AV node or above, so above the level of the ventricles. So it either can be sinus. If it's from the SA node, it will meet the criteria we spoke about on the previous ECG. Atrial dysrhythmia, so these include your atrial fibrillation, atrial flutters, and so on. So those are generally narrow complex, and they do have P waves that are present, but may be abnormal. In atrial fibrillation, you'd see like fibrillatory P waves, so they would you may or may not see them. And then junctional rhythms are junctional rhythms are rhythms that arise from the AV node, and those you won't see any P waves in that rhythm strip. So the P waves is what would make you differentiate whether or not it's junctional or atrial in origin. And then ventricular dysrhythmia, so the wide complex dysrhythmia, so they arise from the ventricles. You'll see them in your ventricular tachycardia and ventricular fibrillations. And then I put bundle branch under this category, but generally there's no dysrhythmias with bundle branch blocks. Generally VTAC or VFibs. So I'd like to start with atrial fibrillation. So you get an irregular rhythm, as you can appreciate on the pulse. When you're palpating the pulse, there's no P waves that you can see there. They were like disorganized isoelectric line there. And then the atrial fibrillation can have a fast or a slow heart rate depending on how the AV node is doing with the AFib rhythm. The reason why you want to check the vitals, the BP and the heart rate, is if you do have a fast heart rate with hypotension and stuff, then you're dealing with a fast AFib, which requires some urgent management. So in terms of management, we go according to the ESC, so the European Society of Cardiology 2020 guidelines. They recommend that all atrial fibrillation should be anticoagulated. What they recommend is that you do a CHADS-VASc score, so that assesses the patient's risk for stroke with that AFib, and then calculate the Hasbled score, which will give you the risk of the patient's bleeding risk, and then you have to compare the two together and see whether or not you should anticoagulate the patient or not. These calculators we'll speak about in a later slide. They're easily available on MD Calc as well. They recommend something like low molecular weight heparin, clexane, 1 milligram per kilo BD to anticoagulate, and then convert to vitamin K antagonist. But in places where resources are available, a NOAC, rivaroxaban, or also known as Xarelto, you can use that as well. Rate control is preferred over rhythm control initially. So if you do have an unstable patient, you'd want to rate control with the synchronized cardioversion. There'll be a slide showing how to do that later on. Or amiodarone, you can use that to chemically cardiovert. If you do not, if your patient is stable, you want to either give them beta blockers or calcium channel blockers if there's no LV dysfunction. So if they have an ejection fraction of more than 40, or you can use digoxin and beta blockers if the LV dysfunction with an ejection fraction of less than 40. So this is just a ECG showing a 12-lead ECG of a patient with an atrial fibrillation. So it's an irregular rhythm. The V1, which sits on top of the AV node, if you look at where the placement is on the chest, has got these coarse fibrillatory P waves. The normal, the rate of this patient is 72, so it's a stable atrial fibrillation. So this is someone that you want to just anticoagulate and then give some time. You can rhythm control as an outpatient with either calcium channel blockers, beta blockers, and then you investigate and treat the cause. So you refer to cardiology, get an echocardiogram to rule out what's causing the AFib. It could be something like heart failure or valve disease or whatever. They would do the echoes and other investigations and figure it out. This is just another ECG of atrial fibrillation. So again, it's irregular. It's got a bit of a faster rate at about 126 beats per minute. So there's a mnemonic for rate controlling patients with unstable atrial fibrillation, unstable or hypotensive patients with cardiovert or give amiodarone. But patients who have normal blood pressures, you can use this mnemonic. So it's A, B, C, D, E. A is for amiodarone. B is a beta blocker. C is calcium channel blocker. D is digoxin. Or E is electricity, which is the synchronized cardioversion. And initially, you just want to pick one of those in the ED to treat the patient and then refer on to cardiology. So hemodynamically unstable patients with atrial fibrillations, in terms of rate, generally you'd look at patients with a rate faster than 150 beats per minute, but other markers would be hypotension with a systolic of BP of less than 90, altered level of consciousness, if they've got cold clammy skin, rising lactate levels, those sort of things. You'd want to do synchronized cardioversion, and in the next slide we'll go about how to do that. Hemodynamically stable patients, as I said, you just want to anticoagulate them first and then try medical therapy, and if it doesn't work, use electricity. There are other guidelines for the chronic management of refractory AFib or AFib not responding to cardioversion or chemical or electrical cardioversion, but that's a separate talk. So yeah, in this slide, I just put up a picture of a defib machine. So if you do have a patient that you do want to cardiovert with an atrial fibrillation, you do not want to use defib mode. You want to use the synchronized cardioversion mode, because they have an ongoing, they have a pulse present with QRSs. So what you do is that you look for the sync button on your defib machine. First, what you do is that you switch on your defib machine, you attach the monitors to your patient, and then you get the rhythm, and then you look for the sync button. In this case, you find it in this corner here. And then once you do press that sync button, you'll see these small dots on top of every QRS on the rhythm strip. And then what you do is that once you see those dots, you set your dial onto the joules that you want to shock at. Initially, you start at 120 joules and then work your way up if it's not cardioverting them, and then charge the defib machine, clear your oxygen, and then deliver your shock. And then you'd want to assess for the new rhythm. Goes without saying, before you shock the patient and before you do all of this, just give them adequate analgesia, something like fentanyl or low doses of morphine, and then just some light sedation as well if necessary, maybe 1 milligram of domicum or something like that, just so that they don't feel that cardioversion. So this is from MD Calc. It's just to show you the CHADS-VASc score. So these are patients that you just plug in these details that you can find on history, and then it would give you a score. The reason why you want to calculate this is so that you don't cause any embolic CVAs, TIAs, or strokes in patients that you are cardioverting. Especially patients who are not, obviously if the patient's hemodynamically unstable, you don't want to save their life and cardioverter them. But we're talking, this is for hemodynamically stable patients. So what this scored, what the ESC guidelines from 2020 say is that if you've got a score of 2 or more, that's when you'd want to anticoagulate them, and then wait for about 3 weeks or so before you start rhythm control on these patients in order to prevent strokes. Obviously, you don't want to tie up the risk of this. You use the Has-Bled score to calculate risk of a catastrophic bleed, and then weigh your options and see if you would continue with anticoagulation or not. Next, we go on with atrial flutter here. So the features of atrial flutter, the pathophysiology behind atrial flutter is that there's a re-entry circuit in the right atrium. So there's an irritable focus of automaticity in the atria, which fires regularly. These rates from the atria are typically very fast. So they go up to about 350. So between 250 to 350 beats per minute. There is the long refractory period in the AV node allows just a couple of these P waves to pass through to the ventricle. So your ventricular rates generally tend to be either 150 or ratios of that. So 150, 75, that sort of thing, depending on how much P waves the AV node is filtering out. What you'll see on your ECGs is inverted P waves in your inferior lead. So there's 2, 3 AVF and upright Ps in your V1. And then the ventricular rate will be a ratio of what the AV conduction is from the P waves. If you, there is a such thing also as a variable block. So sometimes you might see, like in this figure up here, you have 2 P waves and then a QRS, 2 P waves, a QRS, and then 3 QRS, 3 QRS, and then 4 QRS. So that's what you call a variable block. So it's not a fixed block. There's every beat to beat, there's some variation with the block. Most commonly atrial fibrillation will present with regularly irregular rhythm. They usually have regular RR intervals, but if there is a variable block, then you get an irregular rhythm. If the patient's hemodynamically stable prior to cardioversion, you'd want to anticoagulate them. But if you would anticoagulate them in the ward and then do elective cardioversion and refer for ablation. But if they're unstable, then you are justified to do a synchronized cardioversion without the anticoagulation. Causes of atrial fibrillation are generally heart failure, COPD with cor pulmonale, things like atrial septal defects. So it's generally things which cause dilation and irritation in the atria. So this is just a rhythm strip showing an atrial, it's a 12-lead ECG of an atrial flutter. It's with a 3-to-1 block. So there's 3 P waves and then 1 QRS, 3 P waves and 1 QRS. And with this case here, you've got this close to normal or slow ventricular rate because of that 3-to-1 block. This atrial flutter ECG here has got a variable block. So if you look at a rhythm strip down here, you've got 2 P waves, 1 QRS, 2 P waves, 1 QRS, and then you've got 1, 2, 3 P waves and a QRS, and then again 2 P waves and a QRS. So that's what you call a variable block. There's an it will give you an irregular pulse. But the way you differentiate this from atrial fibrillation is that you can see there's there are P waves that you can discern and make out, and it's got this sawtooth appearance, especially in these inferior leads here. Next, we'll go on to the bradycardia and AV blocks. So let's begin with sinus bradycardia. Sinus bradycardia most commonly is caused by increased vagal tone. Generally, you see that in patients, in athletes. They generally, so it's a normal PR interval. It's a regular pulse, but the rate is less than 60. If patients are asymptomatic, you don't need to treat them. The only reason you would treat such patients with a bradycardia is with like very, very low rates where they would present in shock, they have heart failure or altered mental state, those type of things. Generally with the management of bradycardia, so from the ACLS algorithms, they say first rule out the 3 H's, the hypoxia, head injuries, and hypothermia, and then they give atropine 1 milligram every 3 to 5 minutes and to a maximum of 3 milligrams, and then if that's not working, move on to your adrenaline infusions. But from an emergency department point of view, we see a lot of bradycardia associated with issues like electrolyte abnormalities, things like hyperkalemia. You can also have endocrine causes like hypothyroidism. There's also bradycardia is caused by things like drugs and toxins. So if you've got beta blockers, calcium channel blockers, amiodarone, those would give you bradycardia that you wouldn't generally use atropine for. And then toxins, so things like organophosphate poisoning, which we see a lot in our ED. So one of the B's in dumbbells is bradycardia. And then, the last one that the one that we like to talk about is the head injury. So those patients generally, if you have a head injury or a bleed in the brain and you've got features of raised ICP with brain herniation, you get Cushing's reflex, and part of that Cushing's reflex is bradycardia. If you've ruled out all these and if you've done a 12-lead ECG and you see that it's a sinus brady and there's no blocks or anything and the patient is still unstable, that's when you would call cardiology and consider pacing in these patients. So this is just a 12-lead showing sinus bradycardia. You can see the slow rate in the ECG, but you've got normal PR intervals. You've got these long TP segments, so between the end of the T wave and the beginning of the P wave. It's just ECG just to show you sinus bradycardia. Next, we'll move on to the heart block. So the first one is a first-degree heart block. So this heart block is just characterized by a prolonged PR interval because of a delay in the conduction between the delay in the conduction to the ventricles by the AV node. So your PR interval here is more than 5 small squares. Generally, these patients are stable. They don't really require treatment. It's most of the time is caused by increased vagal tone in athletes. But you should also, if you do have patients with these blocks, you should look for, do a full 12-lead, look for things like MIs or myocarditis. If they have chest pain, consider myocarditis. Do a blood gas, look if they have any electrolyte problems like hyperkalemia or anything like that. Or you can also just, in part of your medical history, if the patient is on AV nodal blocking drugs such as beta blockers, calcium channel blockers, digoxin, amiodarone, you can either pause those until they you can either stop those until they're asymptomatic and change them to something else. They generally don't. There's no there's no role for pacing in first-degree heart block. So this is a 12-lead that's just showing first-degree heart block. Of note is just prolonged PR intervals in the rhythm strip, but the rate is normal, so there's not really much going on there. So next one we go on to is a second-degree heart block. So there's two types of second-degree block. The first is a Mobert's type 1, which is also a Wenckebach rhythm, and then you get the Mobert's type 2. So the type 1 heart blocks characterized by a progressive PR interval, PR interval, and then it drops a beat. So if you can see here, it's got a sort of short PR, a long PR here, it gets longer here, it drops a beat. Then here you've got a normal PR, then it gets longer, and then it drops a beat. So the pathophysiology behind this prolonging PR, so the reason why it gets long over time is because there's reversible conduction block at the AV node. And this reversible thing happens because the AV nodal cells that's supposed to conduct the beat are getting fatigued. And because of this fatigue, they eventually, so as they get fatigued, the PR gets longer, and then eventually it just becomes too fatigued to conduct a beat, and it drops a beat. So usually, the suppression or the fatigue of this AV nodal cells caused by your drugs like beta blockers, calcium channel blockers, amiodarone, digoxin, or other cardiac illnesses like myocarditis, MIs, increased vagal tones can also cause it. So usually if you see this rhythm, it's usually benign. Patients are generally hemodynamically stable. They don't require pacing. If they are symptomatic or they're having syncope, dizziness, that sort of thing, you may consider atropine to treat these patients. Mobert's type 2 doesn't have a special name to it, but it's generally it's normal PR intervals. So the PR intervals are constant, and then it drops a beat. So how you differentiate a type 1 and a type 2 is by looking at the PR intervals. And if you've got if you've got regular PR intervals, then that are not prolonging, then it's a type 2 block. This is generally caused by a block at the bundle of His or the Purkinje fibers, and it's not a reversible. So whereas in type 1, the AV nodal was getting fatigued and it was a reversible blockade there. These ones are generally it's a permanent damage to either the bundle of His or Purkinje fibers. What that causes is every beat there's a unpredictable and random pattern where these P waves do not conduct to QRS complexes. So because there's structural damage to these Purkinje fibers and bundle of His, it generally occurs due to infarction, fibrosis, necrosis of those fibers. The QRS that gets dropped is unpredictable, and because it's unexpected and unpredictable, these patients can progress very quickly to either a third-degree block or cardiac arrest, where they're not having any ventricular conduction, and that's what makes type 2 rhythms something that you'd want to admit for cardiac monitoring, something that you'd want to consider early pacing on if it doesn't resolve. There's a 35% yearly risk in patients with this type 2 block for progressing to asystole. So this is just a 12-lead ECG of a Mobitz type 1. So the first part of the rhythm, you can just see that there's a short PR here, or a normal PR, and then it gets progressively prolonged here, and then over here you've got a P but no QRS, and then it starts again like that. This shows a pattern of the AV node cells are getting fatigued over time, and then they take longer to give this impulse to the QRS, and then they finally give up and just drop the beat there. The next ECG, this is of a Mobitz type 2. So you can see there's a QRS, a T wave, and then there's a P wave. There's a drop beat here. There's a P QRS T, and then so this is every second beat where it's being dropped. This in this case, you've got a predictable block, which is a 2-to-1 block, but unpredictability of how this will degenerate, and that makes it a patient that needs to be admitted for monitoring and might need pacing if it degenerates to asystole or third-degree heart block. The atrial rates you can see are 75 per minute, but the ventricular rate in this case is 38, and you'd want to see if the patient's perfusing with that ventricular rate or not. And then the final one is the third-degree heart block. So generally third-degree heart blocks present with severe bradycardias. There's no AV conduction, so you find independent atrial rates and independent ventricular rates. To see this, you can see that these P to P waves, this P wave is being masked by the QRS, but if you see the P waves are generally, the P to P intervals are regular, and then the QRS to QRS intervals are also regular. Generally, this is caused by inferior MIs, AV nodal blocking drugs like calcium channel blockers, beta blockers, digoxin, or you can have degeneration of the conducting system. So if you have a patient with self-terminating blocks, they'll generally present to you with recurrent syncope, and those are patients if you do pick this up, you'd want to admit to cardiology. But patients who probably won't end up to the emergency department are those who do have a non-terminating block. So they end up with sudden cardiac death because they don't regain. So they'll have P waves, but they won't have these QRSs and they won't perfuse, and that would lead to cardiac death if it doesn't self-terminate. All patients with heart blocks would need admission for monitoring, and if they are hemodynamically stable and perfusing, you'd admit them for a permanent pacemaker as soon as you can. But if they are hemodynamically unstable with low blood pressures and stuff, you'd want to consider either cutaneous or temporary pacing while they get to the permanent pacemaker for these patients. So this is a ECG of a third-degree heart block. So the atria are going at 60 beats per minute, which is normal for the SA node, but you can see the ventricular rate is 27 per minute. What you can appreciate here is the wide QRSs. So this ventricle is setting its own pace, and the rhythm is arising from the ventricle. This is just a summary of the bradycardia. So your first degree and your Morbus type 1 AV blocks, you don't really require much treatment. It's basically symptomatic. Treat what's causing it. They don't require pacing. But in your Morbus type 2 and your third degree blocks, those are the ones where you do want to consider either admission for monitoring and to get a pacemaker in them as soon as you can. Next we'd move on to the supraventricular tachycardia. So this is a bit technically challenging, but I'll try to explain as best as I can. So supraventricular tachycardia involve all beats above the ventricle. So that includes AFib, A-flutter, and that. But we've already discussed those. In this section, we'll go through the junctional tachycardias. So generally, the junctional tachycardias won't have P waves. It'll just have a QRST because the AV node is where the focus is coming from of the automaticity. So there's two types. You get an AV nodal re-entry tachycardia and atrioventricular re-entry tachycardia. So AV nodal re-entry tachycardia are patients with normal AV nodes. It's a functional re-entry system. Atrioventricular re-entry is patients with the accessory pathways, so things like Wolff, Parkinson, White, where they have the bundle of Kent and those sort of things. So let's go through the AV nodal re-entry tachycardia. So it's the commonest type of SVT. Commonly causes palpitation, syncope, chest pain, dyspnea, anxiety, those sort of things. You can have a tachycardia of about 140 to 280 beats per minute. The way you pick it up is a regular narrow complex tachycardia. Usually it's provoked by things like exertion, like exercise, caffeine, alcohol. If you're using too much inhaled salbutamol, or if people who use sympathomimetic drugs like meth or cocaine or anything like that. The good news with these is that they're generally really life-threatening and they may resolve spontaneously. So as I said, it's a functional re-entry in this AV node. So in the normal AV node, you've got two impulses that come down. One comes down the slow or alpha pathway, which has a short refractory. So you can see the squiggly line here is short, and then the fast or beta pathway, which has got this long refractory pathway. So the pathophysiology and then this long refractory pathway, and then generally these two cancel each other out in the AV node, and net the fast one conducts down to the ventricles and gives you that normal sinus rhythm. So the pathophysiology behind this AV nodal re-entry is that you've got this the slope whilst there's the impulse going down this fast pathway with the long refractory period, while this pathway is still in this refractory period, because of these irritating foci in the atria, so whatever the caffeine, the alcohol, the meth or the drugs or whatever gives you that, it causes some irritation in the atria and gives you that premature atrial complex. And now this, because this long pathway is refractory, it preferentially goes down this squiggly short pathway. And as it's going down this squiggly short pathway, this long pathway here, the fast pathway here, becomes stops being refractory, so it loses its refractory. So now, because it's no longer refractory, this impulse that was going down this slow pathway ends up going around the circle and going up retrograde up this fast pathway. And what that leads to is a situation where you've got this re-entry circuit or a circular pathway going on in the AV node. Of note, what's happening now is that it's giving off these retrograde or backward impulses up to the P waves, so towards the sine SA node or the atria, and you've got these anterograde or forward going impulses down into the ventricles. So because this pathway is generated in the AV node, that's why you're getting these regular QRS complexes, and these retrograde upward impulses would give you these pictures of P waves. Generally, you don't see them because of the rate, but you may see P waves buried in the QRS complexes. So the important thing with these is the treatment of these patients. So you can initially start with vagal maneuvers if they are stable and cooperative and stuff. But according to the ACLS guidelines, we use adenosine. So when you pick up a narrow, regular, complex tachycardia without P waves, your first, in a patient who's hemodynamically stable, your first choice is adenosine. Adenosine is an AV nodal blocking agent, so it causes a transient block in the AV node. It's rapidly eliminated in the plasma, so the half-life is only 10 seconds, so you have to give it really fast and flush it in really fast. Ideally, you want to give it through a large bore drip in the antecubital fossa with a 3-way stopcock, and that 3-way will help you give the adenosine and flush it in very quickly. You put your patient on the ECG monitor, you explain them the procedure, you get consent. You have to caution the patients that they might feel something like an impending sense of doom or some metallic taste in their mouth or something like that while you're giving the drug. But the first dose you'd give of the adenosine is 6 milligrams. And then if with a 20 ml saline flush, if that doesn't work, you'd go on to 12 milligrams with the saline flush. And if that's also not working, that's when you would choose to electrically cardiovert them. You'd also want to use the synchronized cardioversion in this case. What you'll see is a transient asystole on the monitor, and then it returns to sinus rhythm. So I've just put up a video showing how adenosine works. So you can see this narrow complex regular tachycardia. So here they're drawing up the adenosine. So here they're setting up the 3-way stopcock. So that's the saline flush, and just adding the adenosine to the 3-way stopcock. So notice how quick they had to flush in the adenosine, and then you see that the rhythm goes into an asystole or flat line, and then picks up as a sinus rhythm again after that. Okay, so then the next one is your atrial. So this is still part of supraventricular tachycardia. So the next one is your atrioventricular re-entry tachycardia. So this type of SVT is associated with an accessory pathway. So usually in Wolff-Parkinson's White, you'll see a bundle of Kent. You have to just understand with this pathway. So it's kind of a circular pathway again, but there's two types. There's orthodromic and antidromic, and it all depends on how this impulse is going down this AV node. So in an orthodromic pathway, you get an anterograde, so it's going normally forwards down the AV node, but then it gives you this retrograde or goes back up the the accessory pathway. So this here's the accessory pathway, that's the AV node, and it's going normally down the AV node and upward through the accessory pathway. So in this type of one, because it's going down normally through this AV node, you'll get a narrow QRS complex in your orthodromic AVRT. Whereas in your antidromic AVRTs, your impulse from the atria is not going down normally through it's going down through the accessory pathway. So it's going down through the abnormal pathway and then going retrograde back up the AV node. And then that gives you that circular pattern that's going around and around. So in the antidromic pattern, because it's not going through the AV node, it's going through the accessory pathway, you'd have a wide complex, a wide QRS complex, and this may even mimic a VT. But if you have this type of thing, you would treat it as a VT, as a ventricular tachycardia. So what's important with knowing which one's orthodromic and antidromic. So the way you pick it up is that this one would give you a narrow complex and this one will give you a wide complex. With your narrow complex, you can use things like adenosine AV nodal blocking drugs to control that arrhythmia. But in this case here, you don't want to do that. And the reason why you don't want to do that is because if you're blocking this AV node, this it will give you a preferential pathway through the accessory pathway to the ventricles. And generally, if the patients with, if that you do give AV nodal blocking things like adenosine to, if they develop things like atrial fibrillation and stuff, they will go into sudden cardiac arrest, because when you have a AV node that is blocking these the fibrillation from the atria to the ventricles and controlling that rate, this accessory pathway doesn't do that, and then every AFib wave gets conducted to the ventricles, and that's obviously too fast for the ventricles. You got up to about 500 beats going down to the ventricles, and that gives you sudden cardiac death. So that's why if you see a wide complex, you don't give adenosine. If you see a narrow complex QRS, you do give adenosine. So this is just an ECG 12 lead showing orthodromic AVRT. So it's a narrow complex tachycardia. It's an SVT because you don't see any P waves. And you would manage it as you would for an ABNRT. So you either use vehicle maneuvers, give adenosine, and cardiovert if the adenosine is not working. This is the antidromic AVRT. So these are the ones with the wide complex. And this is a type where you've got the antigrade through the accessory pathway and the retrograde through the AV node. And this is the one where you don't want to use adenosine because it may precipitate ventricular fibrillation and cardiac arrest. So you want to DC cardiovert if you've got a regular tachycardia but with a wide QRS. Okay, and then lastly, we move on to the pulseless rhythms from ACLS. So pulseless rhythms, we can subdivide them into those that are shockable and those that are non-shockable. Before we go into the rhythm, we just want to remember that you still want to use your ACLS principles. You want to still give your high quality CPR while you are treating these rhythms. And then also another note is that if your patient is a trauma patient and you want to follow the ATLS principles of resuscitation and not necessarily ACLS if you have a patient with without a pulse from a trauma event. Your shockable rhythms are your ventricular fibrillation and your pulseless VTAC, and then your non-shockable rhythms are pulseless electrical activity and asystole. So with VFib, you can see there's this rapid, chaotic, and irregular pattern. You need to defib these patients early. So there's studies that show that every minute you delay in defibrillating a VFib is 10% increases your, decreases your chance of survival by 10%. So when they say start chest compressions and get that AED early, this is the reason why. It gives them the best chance of ROSC and survival to discharge. So it often occurs because of ischemic heart disease. Usually the progression is from coarse VFib, it deteriorates into fine VFib and then to asystole. The way you want to defibrillate them. So this one is the one where you don't synchronize it. You just give them the defib dose of 120 joules by phasic or whatever the manufacturer recommends, and 360 joules of monophasic. Ventricular fibrillation's got high ventricular rate of about 500 beats per minute. It can't maintain cardiac output, so it really needs that early defibrillation. ACLS guidelines, if you're unable to defibrillate, if you give the shock and it's still in defibrillation, you want to shock again, but after the second shock, you want to give the adrenaline, and then after the third shock, you want to give the amiodarone or lidocaine. And then there are now further studies with people getting older and living longer with cardiomyopathies, ischemic heart disease, and so on. There's a new thing called ventricular storm or VFib storm, where you shock the VFibs and they just don't get out of that rhythm. And there's now data suggesting that there's now dual sequential defibrillation, where you shock them with pads at the apex and the sternum, and then you want to put a second set of pads at the anterior and posterior of the heart and deliver that shock at the same time using two people if it's safe to do so. Generally, you'll be able to do that if you're using pads and not the pedals on the patient. This is an image that I got from the internet. So your VFib, ideally you should be seeing this either on your patient's monitor or on your defib machine. You don't want to be seeing this on a 12-lead ECG. So it's a disorganized erratic ventricular rhythm. The P waves are different amplitudes and different morphologies. Next, we go on to ventricular tachycardia. So you've got your monomorphic tachycardias and polymorphic VTECs. Monomorphic, you've got a single arrhythmogenic focus in one of the ventricles. It's uniform. It's equal amplitude of the QRSs. There's no P waves. So these ones you'll also want to cardiovert if you do pick that up without a pulse. And then the polymorphic VTEC, there's multiple arrhythmogenic foci. There's QRSs of varying amplitudes. There's also no P waves here. And usually these are caused by myocardial infarcts and things like that. So if you do get ROSC on these patients, you should get a 12-lead ECG and see if there's any patient that you need to refer to cardiology. Here's a 12-lead of a VTEC. There's you can see there's monomorphic VTEC. The QRSs are equal amplitude, usually caused by things like ischemic heart disease, DCMOs, HOCMs. If there's impaired cardiac output, you need to defib these with cardioversion. Otherwise, it may degenerate into ventricular fibrillation, and there's high mortality associated with that. There's a special type of ventricular polymorphic VTEC called Torsade de Pont. This rhythm's twisting around, so you get an isoelectric baseline, but the amplitude of the QRSs sort of gradually gets bigger and then smaller, and it looks like it's twisting around that isoelectric line. It's a type of polymorphic VTEC associated with prolonged QT interval. Often it's short-lived and self-terminating, but some people, if not picked up and not treated, it degenerates into VFib and hemodynamic collapse from that. The prolonged QT is as a result of prolonged myocyte repolarization because of malfunctions in the ion channels. Generally, that's associated with electrolyte problems, so things like potassium, calcium, magnesium abnormalities. And if you do pick up that you do have these abnormalities, you want to replace these in addition to your cardioversion so that your patient doesn't go into refractory torsades. The pathophysiology behind this is there's because of the prolonged QT, there's a PVC that occurs on a T wave, and that's known as a R on T phenomenon, and that's what perpetuates this rhythm of torsades. If you look here, this is just a 12-lead showing you, so that's a normal sinus rhythm, and then here you've got your torsade that's much more increased amplitude QRS going back to low, going back up, and then it's self-limiting and it goes back into sinus rhythm there. This is just a summary of the ACLS guidelines for these VFibs. You just want to make sure that you defibrillate these people early, do the CPR. If they still have the rhythm, you want to defib again and do the CPR. If they're still having the rhythm after two shocks, then you give MEO. You give adrenaline, and if it's still there after on the third shock, then you'd want to give amiodarone or lidocaine. Next, we go on to pulseless electrical activity. So pulseless, as you can see, can have a narrow QRS or wide QRS complexes, and this speaks to the pathology of what's causing this PEA. I just put up the slide here just to show that generally PEAs is where you want to look for your H's and T's as part of your ACLS guidelines. When you get a PA rhythm, you give you continue with the CPR, you give your adrenaline, but while you're doing that, you want to look for these reversible causes. So to address hypoxia, you want to intubate early and you deliver that high FiO2. It also gives you a chance to maintain that greater than 80% chest compression fraction. To address things like hypovolemia, or in trauma patients, things like hemorrhage, you want to give early blood products, or you want to keep your fluids running. Generally in trauma, if you do look at the heart, you'd see, if you do look at the heart on the point of care echo, you would see that it might be a pseudo PEA, and that's why you'd want to control the hemorrhage and give early blood products to try to get ROSC in those patients. Broad complex PEAs are generally the ones where, this is a picture from Rebel EM where they break it down into narrow complex and broad complex, and you can see the narrow complex are the mechanical problems. So things like things that are here on the T side, so things like cardiac tamponade, tension pneumothorax, pulmonary emboli and stuff, and those are the things that you'd pick up on your point of care ultrasound while you while the patient's undergoing the resus. You just look on your point of care ultrasound on the echo. You can see if there's a tamponade. You can do a pericardiocentesis. If there's absent lung sliding, you'd either do a finger decompression or put in an IC drain. If there's features of PE, so if you pick up dilated right ventricle, septal bowing or McConnell's sign, or if there's features of a DVT, you try to thrombolize them intra-resus. So those are the ones you think of with a narrow QRS complex where there's a PA, and then obviously the acute MI. So you'd also want to either thrombolize or do a PCI post ROSC for these patients. And then the white QRS are generally the ones associated with either toxins or metabolic derangement. So things like hyperkalemia. So you do a gas during your resus and with the white QRS, and if you have hyperkalemia, you'd shift that, or if you can do an ECG on your patient, if you get post-ROSC ECG, if you find features of sodium channel toxicity, so dominant R wave in AVR or right axis or anything like that, you'd want to use things like bicarb and that to prevent them from going into arrest again. And then the last one is asystole. So this is just a flat, usually the typical flatline rhythm you see in the movies when someone passes away. There isn't really much to say about this besides just make sure you turn up the gain on all 3 leads of your defib machine or your monitor, just to make sure you don't have a fine VFib rhythm that you can shock. You want to also give adrenaline and see if you can go into any one of those rhythms and see if you can get ROSC that way as part of your ACLS algorithm. The other thing is that you also just want to confirm that there is cardiac standstill on your echo with these patients with asystole before you decide to call the resus. And yeah, that's it. That's my talk. Thanks everyone for listening. Anyone have any questions or anything like that, you can put it in the chat and I'll try my best to answer them.